Hi everyone, welcome. Thank you for joining us for another episode of RACGP Victoria and the Department of Health Victoria combined webinars on COVID. Really appreciate you giving up your time to learn more about the antivirals that are about to enter the market. So we're here to go through that with you. To open the webinar, I'd like to acknowledge the traditional owners of the lands on which we are meeting. I am on Wurundjeri land and pay my respects to elders past, present and emerging, and my respects to any Aboriginal or Torres Strait Islander person who is joining us on the webinar. We have got an amazing webinar as usual because we are a bit spoilt for the support that we get from the experts in Melbourne on COVID and vaccination. And to this evening, I'm joined by Tom Schultz, very well-known infectious diseases physician and advisor to the vaccine program for Victoria. Margie Danchin, paediatrician and vaccine guru, who we know very well. A close colleague and friend of Margie and newcomer to the series, Jess Kaufman, who is a research fellow in vaccination. And from the Victoria faculty, we have Bernard Shu, who is here with us every webinar, coordinating your questions, and is a Deputy Chair of Victoria faculty. And we're also joined by Chris Hogan, who is a lifelong member of RACGP and Victoria faculty and a disaster expert, and has been hosting the Code Brown webinars and will be with us tonight to explain what actually happens once you stand down a Code Brown. So we've got a lot to get through. We're about to start and we'll go through all of the plenary in succession and leave time for questions after. But if you've got questions, please put them in the Q&A. We will endeavour to answer some of the more straightforward questions via Q&A, and the rest we'll do live. We can't communicate with you via the chat because the chat is disabled for us. We can send you messages, you can't send us messages. So just use the Q&A. So thank you once again. We're going to get straight underway with our update from Tom. Thank you, Tom.
Thanks, Anita, for that kind introduction, and thanks for the opportunity to speak this evening. I'll just put the slides up there. Just give me a thumbs up or something if that's all working. Okay, great. So look, I'm going to talk pretty briefly really about outpatient treatments for COVID. I mean, I think it's a hugely exciting space really that we're moving into, and hopefully will be part of the kit bag of really bringing COVID under control and COVID becoming part of the background of infectious diseases rather than a pandemic as such, or having such massive impact. So look, just a little bit on the update in terms of where we are in the pandemic. So we're now really coming down off the Omicron wave, lots less cases and less people in hospital. I think last time I spoke, we had nearly 900 people in hospital. Now we're down to less than 400. And the number of cases is dropping each day. Part of that may be a feature of less testing, but if you look at the rate of positivity, so that's the number amongst the PCRs, which are probably more solid than the RATs because well, they're self-reported, the percentage is gradually been dropping down. It was up over 30% at the peak and it's down now to about 12% PCR positivity. So dropping off. There is a fairly long tail to Omicron, which has been noted around the world, that sort of gets down to a lower level, but they're really dropping down to very low levels. It appears to be taking weeks in quite a number of countries. A few important pieces of information. So 16 to 17-year-olds, are now eligible for a booster. And people have probably heard, but ATAGI last week announced that 3 doses for over 16s is the definition of up to date with vaccination. So they're now using that terminology up to date, which I think is a very good terminology, sort of ties in with childhood vaccination and being up to date, and also the uncertainty going forward in that we really don't know if 3 is it, if there's more vaccines coming up and so forth. But at this point, up to date. Boosters recommended 3 months after your second dose, and the sort of overdue point being 6 months after. So I guess you could leave it out to 6 months, but the recommendation, and of course, the protection only accrues once you have the booster. So recommended to be 3 months after your second dose. I think another interesting thing, and a question that I've probably answered on this webinar a few times, is when will Novavax be coming? And I've spoken somewhat skeptically to this point, but we can say that from next Monday, Novavax will be available. And I know many general practices have ordered Novavax, and also through quite a number of the state-run centres. It'll just be for dose 1 and dose 2 initially. Expectation is that at some stage it will be also registered as a booster, but initially just dose 1 and dose 2, separated by 3 weeks. It's a protein-based vaccine akin to Hep B, pertussis, and a number of the other vaccines that people are familiar with. And we're hoping that some of the 5% of Victorians who are the most vulnerable, that's the percentage who are unvaccinated, may take up Novavax, particularly if they've been waiting for something of a more traditional vaccine and have had concerns around mRNA technology or adenovirus technology that are part of the Pfizer, Moderna and Astra vaccines being relatively new technology. I mean, I think I would argue strongly that with billions of doses around the world, they've now been extremely well tested, but that concern remains for some people. So hopefully Novavax will help a small number of people, hopefully close to 5%, but probably something less than that, get vaccinated initially with their first 2 doses and then subsequently onto a booster, and at some stage potentially used as a booster for the population more widely. Question that has been coming up quite a bit is vaccination after COVID. And so now that a large number of the population has had Omicron, the question comes up. The advice of the Health Department, which is in keeping with the WHO advice and the CDC advice, is that once you're well and you're out of isolation, we would recommend getting vaccinated. ATAGI has said that for the purposes of if people want an exemption, you can have an exemption up to 4 months after having COVID, but no longer than that. But of course, you don't accrue the protection until you've had the vaccination. I think a question does sometimes come up, is it worth delaying it a little bit to get slightly stronger immunity? And there's different opinions on that and no clear guidance. I know New South Wales has recommended 4 to 6 weeks after you've had clinical Omicron, but our recommendation, and as I said, with WHO and the CDC, is once you're well and out of isolation, it's appropriate to get your vaccination. And that doesn't matter what you're up to, whether it's your first dose, your second dose, or your booster. Very rarely it is delayed in people who had the multi-system inflammatory syndrome. That's largely in kids, and in those who've had a monoclonal antibody, although I noticed that the US has dropped that restriction more recently, so we may follow suit fairly shortly on that. So I'll move, that was a brief COVID update. I'll move now to therapeutics. And look, this is a chart from Canada, really summarising your risk of going to hospitalisation, and it's looking at the period December 14 to January 4th, so over really the Omicron wave in Canada, mostly Omicron, probably still a bit of residual Delta, and it summarises it in a number of ways. You can see, well, by gender, but by the number of vaccine doses across the top, by the age group down the side, by the number of comorbidities, and there's clearly stark differences. If you're unvaccinated and over 80, then your likelihood of hospitalisation is 70 to 80%, depending on your gender, with multiple comorbidities. Conversely, if you're less than 20 and you have 3 doses, your likelihood of hospitalisation is approaching 0. So enormous differences, and that helps us stratify which groups are going to benefit from treatment if we can give it to those groups. So that sort of is really what we're looking at, and the risk groups. And each medication has a slightly different group of risk factors that come from the trials that have been used, but this sort of to really stratify which groups are going to have the greatest benefit. So I'll start with sotrovimab, which is a monoclonal antibody therapy. It's now been available for a number of months. It's a intravenous infusion. So it's difficult to access, not impossible, but requires you to get a patient to an infusion centre for a single dose of infusion. And there's now, most hospitals have a system set up to organise that. Recommended to be, well, it's only approved within 5 days of symptom onset, and only if you're not yet on oxygen. And I'll talk about the groups for whom it's approved, and this really applies to all of the treatments. So anyone who's unvaccinated and with risk factors, anyone who's immunosuppressed, so I guess doesn't usually mount a normal response, and anyone who's under-vaccinated and has a high risk of severe disease, so multiple comorbidities, would be worth considering sotrovimab. So in those three groups. And by under-vaccinated, now with the ATAGI definition of up to date with vaccination being 3 doses for the vast majority of the population, under-vaccinated is anyone with less than that. And this is the sort of outcome data from the trial, which is really quite persuasive in the groups, the placebo group and the sotrovimab group, and how many people were hospitalised. You can see many less in the sotrovimab compared to the placebo group, and then deaths. I mean, only very small numbers of deaths, fortunately, in either group. So the relative risk reduction with sotrovimab is very significant, 85% relative risk reduction. I mean, I guess you can see the absolute risk reduction. These were patients who didn't have a particularly high risk of going to hospital in the first instance, in that even in the placebo group, 290 were treated and only 21 went to hospital in the placebo group. So if you think back to that chart that we had earlier, they weren't the highest risk. They were stratified of not low risk, but moderate risk patients of going to hospital. The next therapy that is to become available, and the government has ordered a large number of doses, it's now in some of the hospitals, and just in literally today I received a email from our hospital around how it would be dispersed and which population groups and so forth. So this is nirmatrelvir plus ritonavir, also known as Paxlovid, as a Pfizer medication. Again, recommended within 5 days of symptom onset for people not on oxygen, and it's BD oral dosing for 5 days. And so that's very attractive, you know, not needing to have people requiring going to an infusion centre and so forth is really very attractive. It's got an 89% reduction in hospital admission. Now the data is all sort of, it's only company releases, so it's a little bit hard to access the real dig down deep data. There's a 10-fold reduction in the viral load. It's a protease inhibitor, so anyone who's involved in HIV medication will be aware sort of where that class fits. And theoretically, it should work for Omicron, although the trials were done with Delta in particular and earlier variants. I guess there's a couple of concerns with Paxlovid, and so it requires renal dose adjustment. Anyone with an EGFR less than 30 can't have Paxlovid. EGFR of 30 to 60 needs a half dose. And it's 3 tablets. So normally speaking, 2 tablets of the nirmatrelvir plus 1 tablet of the ritonavir twice a day, so 6 tablets daily. But if you're in the renal dose reduction, you'd only have 1 of the nirmatrelvir component along with ritonavir. Ritonavir is a booster medication, which means it affects your CYP metabolism and hence has interactions with lots of other drugs. So you will need to be aware there's a University of Liverpool website for drug interactions, including COVID drugs, but lots of drugs have interactions with the ritonavir and may be needed to cease briefly for the period that people are on the Paxlovid. Of note, some nursing homes have actually had Paxlovid distributed straight to the nursing homes, and I think it's impressed in some nursing home pharmacies and can potentially be dispensed. So just if you are in that space, be aware of these, the renal dose adjustment and the drug-drug interactions. But I think it's an exciting drug, Paxlovid, and really has a significant potential to reduce hospitalisation. Oops. Now, and so who's it indicated for? Again, the same 3 groups I talked about earlier. So unvaccinated and risk factors for severe disease, that's age over 50 and a number of other factors. Those who are immunosuppressed, and then under-vaccinated, again using the ATAGI definition of what is now up to date with vaccination, and a higher risk for severe disease. And there's a number of sort of stratifications of comorbidities and scoring systems and so forth to define exactly who it's indicated for. The drug, or the next oral option, is a drug called molnupiravir, and it will probably be the first one that's been available. I understand it's with therapeutic goods now awaiting approval. Again, within 5 days of symptom onset, again, for those people not on oxygen. And the recommendation from the Australian Clinical Guidelines Network is only when other treatments are not available. So particularly that being sotrovimab and Paxlovid, the two that I've previously talked about. It's a BD for 5 days. The impact is not as significant. So a 31% reduction in hospitalisation. If you remember, Paxlovid and sotrovimab both had sort of 85 to 90% reductions. Theoretically, it should work for Omicron. Notably, with the molnupiravir, the interim analysis had a 50% reduction in hospitalisation, but the final results are only 30%. Uncertain exactly why that was. The way it works is it misdirects a viral polymerase, which sort of means that you get aberrant viral replication. Because you've got the potential for aberrant genetic replication, if you like, there's a risk of teratogenicity. So with molnupiravir, it can't be given to pregnant women. Men are recommended to not conceive for 3 months after having had molnupiravir. So a little bit tricky in that regard. Again, same groups: unvaccinated, immunosuppressed or not immunocompetent, so slightly different, but essentially similar, undervaccinated who are high risk of severe disease. But then this concern about teratogenicity, so women for contraception for the duration of treatment plus 4 days, and men for 3 months. So really quite a considerable imposition on someone who may take them on the molnupiravir. So I suspect once Paxlovid is widely available, the space for molnupiravir will be much less outside those who maybe have a significant drug interaction with the Paxlovid. And something that hasn't been in randomised trials but has now been in many trials, including in the UK, very large trials, is budesonide. So nice, because it's something we already have off the shelf, easily available, and something that you as GPs are very familiar with. So it can be commenced within 14 days of onset, 800 micrograms BD, again for people not requiring oxygen, and with one or more risk factors for severe disease. Yeah, as you can see with the sort of divide in the curves there, it's not a huge absolute risk reduction, but for a medication that is very benign, has minimal side effects, is usually well tolerated, I think that it's definitely well worth considering as part of the outpatient management of COVID. Just a couple of other things before I leave it and hand over. So dexamethasone clearly has been demonstrated to have a role in COVID, but only for those who need oxygen, so the opposite group of those that I've just been talking about. Another antibody combination that was available, or still is available, is something called Ronapreve, or Regencov-V, a former president of the United States, became quite well known for being a part of this medication's early stages, but it's not effective for Omicron. So given that I think most recent genotypics I saw of COVID in Victoria was that more than 99% is Omicron, really it no longer has a role. The other medication that does potentially have a role, at least theoretical, is remdesivir, if given within 7 days, which has a significant reduction in, again, hospitalisation, but it requires 3 days of intravenous infusion. So really quite a complicated schedule, and it has been used in the US. There's strong trial evidence to show that remdesivir used in this context works, but we've had significant challenges just getting sotrovimab as a single dose infusion up and running, and it's hard to see a space where remdesivir with 3 separate infusions would be preferential to sotrovimab, really only in a situation where we had limited other medications, or potentially if other things are not accessible, so not really widely expected to take off at this stage. So I will hand over now to Louise to talk a little bit about COVID pathways. Thank you very much.
Thanks, Tom. So I wonder if we could just go to the next slide, please.
Oops, okay, sorry. I did go back again. Okay. Yep.
Thanks, Tom. If you don't mind driving for me, that would be just great, okay?
Yep.
So one of the things that I just wanted to inform you about is, so COVID Positive Pathways is a program that was established in 2020. What happens is that people enter the program through filling in a survey with their rapid antigen test. And as Tom mentioned, a lot of the notifications are now rapid antigen, or PCR, they're sent a link to a survey. The survey asks them some questions, including some health questions, but also some social care questions and demographics. And from that, they're triaged into a priority category and then further assessed to go to go into a pathway, either high, which is hospital, medium, which is a gradation from hospital in the home to sort of active contact and monitoring, low, which is really just text messages. And in Omicron, to deal with the numbers, it's not possible to actually call everyone. They get a text message at the beginning with information about how they can escalate, where they can get advice, encouraging them to contact their GP if their symptoms worse, and some messaging around isolation. Also, just prior to Omicron, the Commonwealth had some funding called Living with COVID, and that is actually to set up a function at Health Direct Australia on the national COVID health line. And this new function is if people call the national coronavirus hotline, they push 1. And when they push 1, they're put through a series of questions just to check they're okay, or if they need to be escalated back to us because they need to go on a medium care pathway. The important thing that's also being asked is of people when they call in is, do they have a usual GP practice, and are they happy for that GP practice to be notified? It's just a notification. It's not a referral that they've tested positive. So this is not fully live yet, but it's actually quite important because, as you all know, we've discussed on these webinars many times, many GPs do want to care for their patients, noting that some people won't need care, but you know, do it, and that it's mostly by telehealth with some options to face-to-face. But for most people, and about 90% of people are in either the low or self-care pathway. So only 10% actually end up in the medium and high. And that's a factor of obviously how Omicron is playing out. It was different when we were back under the original variants and Delta. So GPs we've been working about how to do that. So one of the things that a function that's being put into this system is secure messaging to actually notify GPs. And I think this is pretty important because many GPs have been asking to be able to know when their patients are. So at the moment, what we've been doing is we've been piloting in the Northwest Melbourne Primary Health Network and the Eastern Primary Health Network. So some of you will have already received these notifications. Anita, I know you have. What we're really doing is testing the process, the sort of information that's provided and the secure messaging process. And because we're testing them on medium risk and they're currently in the care of health services, there's no action for the GP to take, but is really rather informing. And of course, that means that the GP can know at the practice level, and of course can monitor for long COVID and other things when they come out. So currently we've sent a bit over 2,000 secure notifications. Over 70% were successfully received. One of the things that's popped up is obviously there are some people who are not on secure messaging, but there are also some practices, but also in some practices, they may have changed their name, they may have, do you know what I mean, changed address, and the secure messaging databases are not up to date. So we will be sending out some information about this more generally through the college and through the PHNs, and seeking for GPs to make sure that their secure messaging is up to date, and some information about secure messaging. Of course, the other thing is that not everybody gets the name of the practice accurately. So there may be a few practices, for example, in Torquay that are called Torquay Medical, but they might be, you know, slight versions of what that is, or Surf Coast Medical. So once the system is fully operational in terms of ICT, They will be able to check that against the National Health Services Directory, which is also, of course, held by Health Direct Australia, and so that will actually reduce the number of messages, those combination of things that aren't successfully received. So far to date, we've had very positive feedback about it. We've got ongoing engagement to understand the GP experience, and that feedback will be used to improve the overall notification content and the model and inform the statewide rollout. Now, I just want to put a caveat on this is for people who call into this national coronavirus hotline and push 1, so we won't get everybody, but it's a good start, and we will promote this out to people in all of our communications to individuals who we do know about because they're in our Trevi system and on the pathway. And so it's not a perfect solution at this stage, but it is quite important. And because of what Tom was just talking about, is the sooner that we can connect people to their GPs and let the GPs know, then the sooner that they can be assessed as to whether or not they do go, that they're prescribed the oral antivirals. And GPs are best placed to know about the comorbidities of their patients and their specific circumstances. I think there is something that I'd like to float as well, that we could be asking. Obviously, none of these drugs are yet on the PBS, but when they do come on the PBS, and they will at some stage, is to proactively think about having conversations with patients when they're in front of you who you think might fall in that category, and ask them to contact you if they have a positive diagnosis as COVID. Because that will actually as well help to reduce the time. And obviously we don't want to scare people, but I think if folk know that there are some options and help open to them, but they need to let you know as soon as possible. So these are just some of the things that are in way as we continue to be pretty adaptable and flexible as much as we can in responding to new science and new technology. I think that's it for me. I think I only had one slide, didn't I, guys?
Thanks so much, Louise. So just while we're changing over the slide pack, I think that that's a really key message, that in terms of health promotion, to mention people who are at risk of poor outcomes with COVID, and say, if you do get COVID, please let us know as soon as you know. We can advise you if you're a candidate for antiviral therapy, because the window, it closes quickly. So a key message there for us to communicate to our patients. I'm going to hand over now to Jess Kaufman and Margie Danchen to take us through some vaccine updates. Thank you.
Thanks so much, Anita. Just before I hand over to Jess, I just wanted to say a couple of words around the COVID rollout for the primary school kids. So we know that this started on January 10, and we're about 5.5 weeks in now to the program. And there was a really fantastic initial burst of uptake with the program in this age group over those last few weeks of January, and people sort of preparing for school. But it really has tapered off now to, I think the last information I saw was around 53% of kids had received 1 dose. And we had projected around 80% would receive 1 dose by this time point. So I think we are faced with a bit of a challenge in this age group, and potentially in the under 5s as well. And I think that's largely due to a lot of mixed messaging for parents, predominantly around severity. Obviously we've been careful to message and convey to parents that COVID is overwhelmingly a mild illness in kids, and 1 in 5 may be asymptomatic, as we talked about at the last webinar. And many parents have seen their own children or kids in this age group get infected and recover quickly. But severe disease can occur, probably less than 1% of children need hospitalisation, but multi-system inflammatory syndrome can occur in kids. So we do really want to encourage vaccination in this age group, but I don't think it's been helped as well for parents to see programs internationally, such as in the UK, where they've adopted only a high risk program, or Norway, which is not actively recommended vaccination in this age group. And I think it's also been swept up a little bit into the messaging around boosters for adults and people being confused, why do I need another dose? How many doses will I need? You tell me I need 2 doses for kids, but, will they need more? And of course, you're having these conversations every day. So what I think Jess is going to really talk to now is how can we support decision-making for parents? What information are they seeking? How can we balance this decision-making against their concerns around safety? And that seems to be predominantly around, potential long-term risks of the mRNA vaccines or Pfizer, as opposed to myocarditis now, with a bit of reassurance around that being so uncommon in this age group. So we thought this was a really good opportunity to just talk about how we can support decision-making, and then we'd really welcome your questions if there's time. So I'll hand over to you, Jess.
Thanks, Margie. As Margie said, I'm sort of coming into this from a vaccine communication standpoint and talking a little bit more about some of the tools and strategies that we can use to encourage uptake and to reduce hesitancy, which of course is one, but not the only reason that we might be seeing lower uptake in this age group. I guess this is just to remind us all that, of course, we can't really tell where people sit on this vaccine hesitancy spectrum when it comes to COVID vaccines, and particularly when it comes to COVID vaccines for kids. So we know that there are a lot of parents who have been double vaxxed, triple vaxxed, but have concerns about their kids, or there are parents who have vaccinated their adolescents but are still not sure about the kids. Even parents who have vaccinated their kids with all the routine vaccines may have questions about the COVID vaccines. So it's really every conversation with parents about the child COVID vaccines kind of starts from scratch, and identifying sort of where people sit on this spectrum is the first step in really having a successful conversation, and of course making sure that we're not alienating people with questions, because a lot of people are quite concerned that they'll be labeled as anti-vaxxers if they do have questions. And so we want to, of course, be encouraging them to ask those questions and have these conversations. Next slide, please. And so throughout the whole rollout, the discussion about vaccines with GPs like yourselves is really one of the most important factors in encouraging people to get the vaccine, in moving people towards acceptance from hesitancy, and that absolutely continues throughout this more fraught kind of child COVID vaccine decision-making space. I'm sure that all of you are well versed in having these conversations now, but just to sort of walk you through some of the key steps, and this is drawn from a large body of evidence around talking about all kinds of different vaccines with people of all ages, but it's about really starting into those conversations with an open mind and asking people to share all of their concerns before you start jumping in and trying to correct them or trying to answer their questions, because we know that a lot of times the main concern or the main reason that someone might not vaccinate isn't the first thing that they'll share with you. So once they've sort of shared all of their concerns and you can kind of summarize them back to the person, that helps you identify what the main concern might be, and it gives you a structure for how you're going to approach the conversation to keep it efficient and to make sure that you're focusing really on the thing that is driving their decision making first. We want to acknowledge that having concerns is really normal. There has been a lot of different information, and as Margie was saying, some sort of mixed messages about the necessity of the vaccine, which I think is an important element to consider here. And of course, avoiding over reassurance. If someone has concerns about vaccine safety, we want to make sure that they put those concerns in perspective, but we don't want to be overstating, I guess, our confidence in any sort of vaccine safety or medication safety. I think talking about the disease itself is important, particularly with the child rollout, because as Margie was saying, so many people have that experience of a relatively mild experience of COVID with kids, or they know someone who has. So not as many people are maybe aware of PIMS-TS and of some of the more serious, outcomes, or they may be concerned about long COVID. So that's something to maybe bring into the conversation, and then making that strong recommendation to vaccinate, and then leaving the door open so that if they want to come back another time after they've read some more information or thought about it, they can of course come back, and it might take multiple conversations to move them towards vaccine acceptance. Next slide, please. So today I really want to highlight a few types of resources and examples of resources that you can use in your clinic, in your discussions, to maybe support or supplement these kinds of conversations, because we know that the conversations can take a long time and you have limited time available. So it might be helpful to point people to some of these resources. The first is really a specific decision aid, and decision aids, as I'm sure you've used in other contexts, are quite detailed, and they're designed according to international standards, and they are intended to really present all the options and the evidence around all the options without a firm sort of push towards one or another choice. This can be kind of a tricky line to walk with vaccines, because of course we do really have a particular choice that we prefer that people select, but it can be really helpful when someone is genuinely on the fence to make sure that we are not pushing people, that they don't perceive that they're being pushed towards a particular decision. And a good decision aid will use visuals to compare the risks, and particularly to put numbers into context. So they can be quite helpful for people who maybe have lower levels of health literacy. And this one that I've linked here is developed by the National Center for Immunization Research and Surveillance. The one I've showed you here is about adult or older adolescent COVID vaccination decision-making, but they have just finished developing one for the child rollout, which I think is going to be launched any day now. And it really does, it's interactive, and it allows people to click through, see the different risks and benefits, work through some of their values and things like that. So this could be something that you either use in a clinic, in an encounter, or something that you point someone to spend a little time before or after the encounter working through, so that they become a little clearer in their decision making. Next slide, please. Another option that you can use, and this is where we have been doing some work with the department to develop something for you and for people to use in these conversations, is an option grid. And an option grid is a much briefer form of presenting the options, I guess. So it doesn't go into as much detail with the evidence as a decision aid, which does mean that it doesn't need to be updated all the time either, but it also means you've got to kind of link out to other sources of information if people want, the details of the peer-reviewed studies and things like that. An option grid set up with sort of the key frequently asked questions, and then how those questions would be answered with either option. And so what we're working on developing with the department at the moment, which should be released really soon, is an option grid where we're talking about if you vaccinate now versus if you wait or don't vaccinate your child. And this will be one page, and so it can be used right away in an encounter. You can pull it out and actually work through it with someone in the discussion, and it shouldn't take up too much time. Next slide, please. And then on the other side of this option grid document that we're developing, we've got a values clarification exercise. And this is something that's an interactive opportunity for people to think through the pros and cons of a decision, but also to think through what really matters to them. And the key with this, I think, for the child rollout is really helping people to think through and beyond the outcomes that they might be focusing on. So we think about, the vaccine, will it prevent the disease? Is the disease serious? Those aren't really the only two things that we want to encourage people to consider. There's other elements, including, just having peace of mind if your child's out playing with people, or are they actually in an environment where they're exposed to someone who is at high risk of COVID regularly, or do they spend a lot of time with someone who's exposed to COVID a lot, so that your child's at higher risk of exposure. So these are different sort of aspects or nuances of the decision that the person can kind of work through and maybe tick whether they think that's important to them or not. So again, this is something they could do before they come into the clinic that helps them get their head around the decision, or it could be something that you talk through while you're helping them make that decision on the spot in the clinic. Next slide, please. So those two resources, just to clarify, those will be a printable sort of PDF type thing. It's in design sort of with the department at the moment, and I'm sure will be released and pushed through RACGP channels and also made public on the department website as soon as it's ready. So sort of stay tuned, I guess, in the next couple of weeks for that. I just wanted, before I finished, to flag the importance of also talking directly to kids, and that element of making sure that the child understands why they're getting the vaccine, has a chance to ask their own questions. I mean, we've all been so steeped in COVID and misinformation, and kids are no different. So giving kids an opportunity, or even just encouraging parents to give their kids an opportunity to ask their questions, provide the information that's sort of age appropriate, but that sort of reassures them, and really making sure that they know that this is something that's not just about protecting themselves, but that it's something they can do to help protect other people in the community, which gives them that sense of purpose, since they haven't really had, anything that they can do to help throughout the whole pandemic. And that has been a challenge, I think, for a lot of kids. So setting clear expectations. The department has lots of resources for, advising parents who need different support, needle-phobic kids and kids who need support for accessibility needs and things like that, which I'm sure you've had lots of presentations about already. So just making sure that kids know that they will be well taken care of as well. I think that's the last slide that I had. So I'll hand back over to the team. Thanks.
Thanks, Jess, and thank you so much for joining us and for that information. Appreciated. We'll move straight over to Chris, who's going to give us a little post-Code Brown update, and we will leave some time. We've got some good questions to get through before we finish. Thanks, Chris.
Okay, if I could have the slides, Con. Okay, these are some slides that we've got directly from the department. Next slide, thanks. Okay, as you know, Code Brown has been, de-escalation has been started from the 14th. The next steps are the system remains under pressure. Standing down Code Brown does not remove the protections and initiatives in place before its commencement, such as alternative workforce and surge models of care. The Health Service Response Centre, which was activated early in the COVID wave to manage COVID. Oops, what happened? Sorry. To manage COVID, will oversee and coordinate the return of services, including elective surgery. This will be done stepwise, and the health system should remain in a state of readiness. Next slide, please. The new normal, as far as the hospitals are concerned, there will be a continuum of public health restrictions to protect the health system. Outpatient appointments, elective procedures and therapies will be assessed and reviewed. The lifting of surgery restrictions is starting now for private hospitals, and which are less involved in the direct care of COVID. Patients waiting for non-urgent elective care should reach out to their GP if their condition gets worse, so they can be reprioritised. Next. An approach to system-wide strategy development is being developed, and this will involve balancing the need to catch up on care and readiness to pivot in response to a flare of a future variant of COVID. So there's prioritisation of care, embedding health service partnerships, collaborations, consolidations of activity, strategic commissioning from private health services. Next. Well, that was from the department. This is my contribution. My father used to tease me that my job was coughs, colds and sore holes. And until that was a pretty common community perception at that time, but then along came COVID, and people can now die from colds, which is really just a symptom of how significant the change that we've been through is. COVID's had a severe impact on our society and all elements of our health system. Now, the declaration of the Code Brown was an acknowledgement that our system was overwhelmed, that normal practice was no longer possible, not only in hospitals, but in community practice as well. Now, GPs have had to limit their scope of practice and deal primarily with acute presentations, which leaves us with a burden which we have to face. We are also aware that many patients were deliberately avoiding face-to-face consults. So this means that there's going to be a considerable burden of undiagnosed illness in the community. There's also a considerable burden of poor control of chronic illness. And now, traditionally, general practice was reactive and simply takes dealt with the patients they saw in the practice on the day that they came. But now it behoves us to review our medical records and recall people with chronic illnesses who need regular review. The only issue is when. We have a lot of workforce issues that we have to deal with. A lot of people are exhausted. As soon as things settle down, we'll love a break. And the other thing too is that we also have post-COVID syndromes to deal with. So basically things are getting a little bit better at the moment, but we have enormous challenges. One of my colleagues who works in a public hospital was told that the waiting list for endoscopies in her unit was 3,000 at the moment. So we have some real issues, and I would think that it's a matter of being prepared for it and also communicating with our colleagues and our assistants to be able to get it through this situation, which can only be considered to be challenging in the extreme. Thank you.
Thank you so much, Chris. Really, there's a lot the general practice can do to support the hospitals that are beginning to come out of the code brown, and there's going to be an iterative return to normal. We're really going to have to think about how we identify and work with patients that are underscreened, have not been attending for management for the last 2 years. I don't think that we have all the solutions for that, but it's certainly something for us all to think about and perhaps come up with a practice-wide approach to going through those patients with higher needs. Before I start with the questions, which there are some pretty juicy questions as usual, I'm just going to throw back to Tom for a couple of additional comments about the update and where we're at in Victoria.
Thanks, Anita. Look, just one final, and I'm going to put it as a challenge to all GPs, really. It's a challenge to all of Victorians. At the moment, the booster program is going okay, but there's people we really need to get boosted. And the people I'm worried about particularly are over 70s. So as of, I think yesterday, 76% of those over 70 have had a booster, but that of course means 24% haven't had a booster. And of any group other than the unvaccinated in Victoria, they're the group I'm most worried about ending up in hospital and at worst case dying of COVID. So anything we can do to encourage them to get vaccinated, and particularly aware that a lot of them had Astra for their first 2 doses, so their protection isn't as strong as it might have otherwise been at this point. So that's the challenge going forward. I'll take questions.
An excellent point. That's come up in a lot of the vaccine advisory groups, etc. And I think we have to remind people why boosters remain a very valid prevention activity. So, you know, the pandemic isn't over or near over, and those first 2 doses are not enough. They're key messages. It's still very important for us to do these vaccines. Now, really interesting questions here. Does anyone in the know, being this learned panel, know whether Novavax will be given in the future to children? Because partly concern, of course, about childhood vaccination is the same concern for adults, but probably you know, burgeoned because we're dealing with minors in the mRNA technology in the myocarditis, pericarditis space. So do we have any intel on the role of Novavax in children as yet?
I can make a comment about that. I know that Novavax are testing their vaccine in kids and that there are trials underway, but we don't have the data yet. So I think it's a bit of a watch this space. But again, I wouldn't be encouraging parents to wait. We just don't know what that will look like in terms of their results, but they are definitely testing it.
And I think also a point is that as long as the longer you wait, the longer you have an unprotected child exposed to a preventable illness. So, and that's a real, everyone's back at school now.
Kids, yeah, absolutely, Annette, and particularly kids with medical risk factors. You know, I do think we need, again, similar to what Tom was stressing around boosters and people over the age of 70, you know, kids with medical risk factors, and that includes things like obesity and diabetes, in addition to, you know, congenital cardiac disease, chronic lung disease, and so on. You know, we really do want to prioritise those kids being vaccinated.
Yeah, absolutely. So we know that there are some people now, because of the myocarditis issue have sort of suspended their activity in vaccination. We're not really using a lot of AstraZeneca, I can say, as a booster, although it's not totally off the menu. So what is going to be the role of Novavax for patients who have had myocarditis, understanding it's not yet officially licensed for use as a booster, but we may have somebody who's in a state of suspended animation, having had one vaccine, mRNA vaccine. How do we utilise that vaccine in the post-side effect population?
Yeah, it's a tricky question, Anita. It hasn't yet been authorised for that indication, but I think at some point it will make sense for that to become the case. Currently, if someone has had a significant problem with mRNA vaccines, then Astra would be recommended as the booster. But I think going forward, Novavax may well fill that space.
And just a question of my own, there's sort of an emerging narrative that AstraZeneca sort of did you good in the pre-Omicron days. However, if you are an mRNA initially vaccinated patient and then you put AstraZeneca after, are you getting ongoing protection given we're now dealing with Omicron? Do we know that?
Yeah, good question, Anita. Once we start sort of doing mixing schedules and slightly unconventional schedules, the evidence base really becomes much less, and it sort of becomes a first principles. I mean, I think we know that Omicron, Astra still provided pretty good protection against severe disease from Omicron. And I think there's a narrative that Omicron is mild. Omicron is more mild than Delta, but Omicron is not mild. And there's a pretty likely story that if it had all gone in reverse and we had Omicron first instead of Wuhan strain first, Omicron would have caused problems not that dissimilar to Wuhan strain. So, that sort of narrative, I guess.
Yes, it's the chopping off your hand is not as bad as chopping off your arm, but it's still actually a really major injury, and we've got to keep that perspective. I'm going to come back to Greg's question because that pertains to antivirals, and just continue with the vaccine theme for now. This is a really important question in general practice. A child in particular, but any person who has had COVID now has this brilliant natural immunity. Therefore, vaccines become redundant, and we really need to be able to speak to this. Can our experts, if I had just said that to you about my child, Margie, Tom and Jess, what would you say back to me?
Well, unfortunately, that isn't true. Natural infection does obviously stimulate the immune system and create antibodies, but the child does still need to receive the vaccine and have that sort of systemic immunity as well, on top of the sort of more mucosal-induced immunity from natural infection. So the child still does need to be vaccinated. As Tom said, the timing around that, there's been a little bit of discussion, but I think most people agree now that once the child is well, they don't really need to wait. They can go ahead and start their vaccine course, and it would be the same, 2 doses, 8 weeks apart or 3 weeks apart if they're in a high-risk group, but they definitely do still need to be vaccinated. I don't know if you want to add to that, Tom.
Yeah, no, thanks, Mark. I think that's really good. I think what we did see is that Omicron probably provides pretty good protection against getting Omicron again, but it's the protection against the next variant. And we saw that with Delta, that Delta didn't really provide great protection against Omicron. Will Omicron provide much protection against the next variant? You're much more likely to have protection against the next variant if you've got having had Omicron plus a vaccine as opposed to Omicron on its own.
And is natural immunity enduring, or is it waning, such as it is with influenza, for example?
So it's definitely waning, but that's a bit of a how long's a piece of string. So how much is it waning and how significant is that, and what's the protection against severe disease and symptomatic disease and those sort of things we haven't absolutely teased out, particularly for Omicron, which of course has only been around for 6 weeks or so.
Yes, thanks. This is a great operational question, and this comes out, and Tom, we have spoken about this before. If we've got a person who is recovering from COVID, and I'm going to use the 30 days here 30 days after they first became symptomatic, but they've got enduring symptoms, or they get cured of their symptoms and then start coughing again, what do we tell patients about the likelihood of them having COVID in that period of time and needing to be tested and needing to quarantine?
Tricky question.
It is a tricky question. You go, Tom.
If you've had Omicron, you're highly, highly unlikely to get Omicron in the next 30 days. So, but in that sort of transition period when we went from Delta to Omicron, you know, some people did go Delta and then Omicron quickly shortly after. Generally speaking, getting retested in that period just adds to the confusion, because if it's negative, that's good, but if it's positive, is that still lingering virus from the previous episode, or is that a new episode? Very, very difficult to tease out. So it is tricky in terms of, I mean, I think our overwhelming guidance now for anyone is, if you've got respiratory symptoms, stay at home, and stay at home until your symptoms resolve and in isolation. Now, whether that's strict COVID isolation or just more general, you know, keeping away from others until your symptoms resolve.
I think Louise is about to mention the issue of emerging other viruses and influenza. And I know, Louise, that's what we've been talking about this.
Thank you, Anita. You can read me like a brook. So I'm going to be really opportunistic here
Yes.
as well to say, for the last 2 years, we have prevented the flu and an enormous number of other viruses. We've been locked away. Our immune systems are lower. The borders are open. There'll be new variants coming in. We're not quite sure. So what we're hearing anecdotally is that people are doing a RAT. It's negative. They still feel like crap. That's a technical symptomatic term, by the way. They retest. They might go for a PCR, but what they've actually probably got is unseasonal flu or some other virus. And I think for older folk and for the kids, you know, because as we know, we've seen cycles of it. So always consider other viruses as well. Perhaps not in exactly this question you're asking, but as you know, always opportunistic here, because we are heading towards flu season, and we do need to encourage everybody to get vaccinated for the flu, and not immediately think when they're ill that it could only be COVID. Obviously, we want them to test for COVID first, but if negative, seek some further advice.
And please make use of the GP respiratory clinics for assessment as well as testing. That's what they're there for. You don't have to invite this into your own room, but these people need to be assessed for illness and for pneumonia and for adverse sequelae.
Yeah, thanks for reminding about that, Anita, because the GP respiratory clinics are on the website. There's the original Commonwealth ones of, you know, nearly 30. We're standing up 20, 16 of those are operational, with more to come online, and we'll be looking to do another 8. So they're there for this purpose, to do respiratory assessment, including on kids.
Thank you. Look, we've got time just for one last question, which is important, and that's we have a person who has perhaps had even up to 3 doses of vaccine, but are immunocompromised, significantly immunocompromised. Do those people still, are they still considered for antiviral therapy? And if they receive the antiviral therapy, what do you do with the 3rd or 4th dose that they are due?
Yeah, so if you're significantly immunosuppressed, then your initial regimen is 3 plus your booster is 4. So I guess if you're less than that, you're considered under-vaccinated, and so hence you would potentially qualify for the sotrovimab or antiviral therapies. And so I think that was the question, was it?
Yep.
And then do you get the booster dose after that, I think was the next.
How do you time your booster dose after sotrovimab?
Yeah, so the current recommendation, which may change, is that if you've had sotrovimab, you shouldn't have a vaccine for 3 months at least after sotrovimab. The CDC in the US has actually dropped that restriction, but currently that remains a restriction here.
3 months. Look, I can't believe it's 7 o'clock. It goes so quickly every time we have a webinar, but I want to thank you all so much for joining and giving us this information, keeping us abreast of what's probably the fastest moving event in medicine in all of our living histories that I certainly can attest to. So thank you very much for supporting VicVac, and we will have the next episode of the webinar in a month's time. So enjoy your evening, everyone.
Thanks, Anita.
So, thanks, Anita.